Hi, everyone. My name is Claudia Offner. I am the technical manager for the session on accelerating integration of prenatal multiple micronutrient supplementation into antenatal care services, a session which will be chaired by Martin Mwangi. Thank you all for taking part in ANH 2022, and we look forward to a robust and interactive session today. Just a quick reminder that everything you might need to access for the conference in terms of material and program will be found on the ANH Academy website. Thank you so much for your time, and over to you, Martin.
Thank you so much, Claudia, for that introduction. Really well said. Ladies and gentlemen, welcome to our session on accelerating the integration of prenatal multiple micronutrient supplementation into antenatal care services. Going forward, I will simply refer to multiple micronutrient supplementation as MMS, just so that we keep conversation easier. And during this the next 1 hour session, we want to explore how we can increase the understanding and insights regarding MMS and all the processes of introducing MMS into a country at national level and scaling it up so that we can be able to fight maternal malnutrition, how we can advocate for MMS. We're going to be discussing with people who have had this firsthand experience in the next 1 hour. And we hope to also increase awareness and understanding of the scientific evidence behind MMS, why we say that it's evidence-based, it's cost-effective, and it's an affordable intervention. And therefore, join us on this 1 hour deep dive into the world of MMS. And with that, I want to first share a small video, because this is all about maternal malnutrition and why are we worried about the health of our women. I will share a small video which has been put together by Healthy Mothers, Healthy Babies Consortium about the life of a typical mother from Ethiopia.
አንደኛ ገበሬ ሚስት ስለሆነች እርፈት የሚያላት
አንደኛ ወላድ ነን ነው፣ ሁለተኛ እዛ ተጨብጠን እንውላለን፣ ሶስተኛ መንገድ ላይ ስንጨመር የአርሶ አደር ሚስቶች የምንጎዳደው በዛ ላይ ነው። በርግጥናችን ላይ እርሻ ቦታ መዋል በጣም አድካሚ ነው እንጂ ልጆቼ ራሳቸውን እስኪችሉልኝ ድረስ እስከተወሰነ ድረስ ፀሐይ እስከሞቀ ድረስ የቅርብ ስራ ካለ ልጆችን ከራሴ ጋር አዝ የምሰራበት ስራ ይኖረኛል እንጂ ልጆቼ ራሳቸውን እስከሚችሉልኝ ድረስ ለሰው ሆነ ላላደለ ሰው አምኛ አስጠግቼ ጥዬ የምወጣ ሰው አይደለም። ውሃችን እንግዲህ ወንዝ ነው። የሆነ የተወሰነ ርቀት አለ፣ ትንሽ ርቀት አለ። ያንን ውሃ ቀድተን እስከምንመጣ ያና አንድ ህፃናት ቤተሰብ ሰው ካለለ ጀሪካ በኋላ ልጆችንን በፊታችን አድርገን ነው የምናሳድገው። ልጆችማ እንምኖረውን አይነት ኑሮ እንዲኖሩ አልፈልግም። አሁን ባለኝ እርግዝና ውስጥ የሚያሳስበኝ አንደኛ ጤንነቴ፣ ሁለተኛ ስወልድ የሚጠበቅብኝን ነገሮች እነዚያን ነገሮች ለማሟላት እስካሁን ያሉት አጋዥ የእርግዝና መድኃኒቶችን እስካሁን በነፃ ነው የምንጠቀመው አሉ መድኃኒቶች። ግን ግዴታውን አስፈላጊ ነው በግዢው ገዝተሽ ነው ተብሎ ተጽፎም ሆነ ተብሎ ቢሰጠኝ እስከቻልኩ ራሴ ሄጄ ካታደስኩበት ቦታ መግዛት ይችላል። ባይኖረኝ ተበድሬ ከዛት ለምን ቢኖረኝም ባይኖረኝም ያን ነገር ካለኝ በቤቴ ካለልኝ ተበድሬ በእርግዝና ወቅት አሁን ባለው እርግዝና ባሁኑ ማለት ነው። በባለፈው ሰዓት ያው ድርቅ ነበር። ድርቅ ነው አንዴ እርዳታ ተብሎ እርዳታ ልንረዳ ሄደን ሳለ ከዛ አሁን ዛሬ ምን አይተሻረከሽ አሉ። እኔ ይሄ ወቅት ይመጣል እንዲህ አይነት ቀን ያጋጥመኛል ብዬ አላረገዝኩም። ያንን ትንሽና ወንድም በማጣት እና በማገኘት ላይ
አንዳንዴ ሲሟላ አንዳንዴ አይሞላላት ነው ሁሉ ጊዜ ሙሉቃል አይሞላላት እየፈለገ ፍላጎቷ እንትን እያለ ምን ስትፋጋ ትውላለች ያልተቤት ያለው ነው ሙሉዋን ስትፋጋ ትውላለች መከራና በይወረጅ ትይላትም ስትፋጋ ትውላለች ምግብ የቀረበ ጊዜ ያው ስንበላ ያው በቃኝ ቆረጠኝ ሆዴም በዚህ ያለ ወጋ ተሰማኝ እያለች ምግቡን በጣም አጎስ ጥሩ ሚስት ባሏን ትመግባለች ልጆቿን ትመግባለች ቤተሰቦቿን ትመግባለች ቤተሰቦቿን ታስቀድማለች አንበሳ ናት።
በሴቶች ላይ ያለው ጥንክርና ማለት ነው እንደማገኘትም እንደማጣትም ቤትን ተብላለች ሴት ስትሰጥ ያንን ጥንክርናዋን ኃይሏን ይዛ ማጣቷን ማገኘቷን ታውቃለች ሴት ማለት ነው። ምግብ ሲቀርብ አንድ የቤት ባልተቤትን እናታቸው ቅድሚያ ካመበላ እነዛ ልጆች ቅድሚያ ቢበሉልኝ ደስተኛ ለምን እኔን ቢርበኝ ባለቤት ነኝ እንደማጣቴም እንደማገኘቴም ልችለውም ልራብበትም እችላለሁ። ያቺ የቤት ባልተቤት ግን ቢተርፋትና እነሱ በኋላ መብላት ትችላለች። ካልተረፋትም እንደማገኘቷ ሆና ትኖራለች ማለት ነው ሴቶች።
So for this, in the next 8 minutes, I'm going to introduce the global scope and scale of maternal malnutrition. And the Healthy Mothers, Healthy Babies Consortium is one of the programs that is part of the Micronutrient Forum. And you can see the other programs that are under the Micronutrient Forum. And using the Healthy Mothers, Healthy Babies program, we try to elevate the plight of mothers. We try to advocate for the role of micronutrients as far as fighting for maternal malnutrition is concerned. Now, globally, many women lack the adequate nutrition. And we know that there are 3 major indicators that we use to assess the health of a mother or of any human being for that matter. And so one of them is low body mass index. And underweight pregnant women face a greater risk of preterm delivery. And when we look at that particular metric, 170 million women, or 1 in every 10 women of reproductive age, are underweight. Now, the other metric that we like to look at is, or other indicator that we like to look at is anemia. And we know that children born to anemic mothers are more likely to be born too early or too small and face an increased risk of being sick or even dying. So when we ask ourselves how many women globally are suffering from anemia, the numbers are just staggering. So 570 million women, or 1 in every 3 women of reproductive age, are anemic. And that translates to their baby, and that translates to the possibility of the baby getting sick or even dying. And when we zoom in to some specific regions, and then we use, say, the Southeast Asia to explore the 3rd indicator that we like to keep an eye on, which is stunting, or what we call being short for your height or being of short stature, we notice that the numbers are also significantly staggering. So 35% of women in Southeast Asia, and this is largely what you would find in other regions, for example, like Africa, the numbers would not be very different. You find that women would be short for their height or would be of short stature. And this being short leads to serious risks of in terms of the woman's health, and increases the chances also of their child being born also stunted. And this fuels the intergenerational cycle of malnutrition. And so women also lack access to quality health and nutrition. Globally, many women of reproductive age have not, over successive generations, had what you would call an ideal diet, an ideal access to health and nutrition. And the COVID-19 pandemic has also come in to compound this problem. So first, 38%, only 30% of women currently receive 90 or more iron and folic acid tablets during their pregnancy. Now, this has been what has been recommended, but we see that the number of women accessing what has been recommended before is abysmally small. Then only 59% of pregnant women attend 4 antenatal care visits. And for those of us who are in public health, we know that since 2016, the World Health Organization recommended that actually pregnant women should make at least 8 antenatal care contacts. And this further increases the gap of women not being seen by a skilled professional like a nurse or a midwife at a healthcare facility. Each year, 20 million babies suffer from low birth weight, which is an early marker of poor maternal and fetal nutrition. And then, as I said, COVID-19 has come in to complicate the scenario, because now it's leading us to other worst case scenarios. If I can just quote some of the data that we are receiving from one of the programs at the Micronutrient Forum, which is a Studying Together for Nutrition Consortium, they project that there will be an additional 283,000 child deaths over the next 3 years, which translates roughly to 250 child deaths per day. Also, 13.6 million wasted children with high risk of death, an additional 3.6 million children with lifelong physical and cognitive impairments due to stunting. And when your child is cognitively impaired, that also impacts their life earning potential. Further, 4.8 million more women afflicted with anemia. So these numbers are what make us spend sleepless nights wondering, what can we do about this situation? Now, poor maternal nutrition has dire consequences for communities and the world. And we know that poor nutrition in infancy and childhood leads to economic disadvantages for the individual. And this would last for over 30 years. And would affect their families and also the generations that come after their families. Well, simply put, if you're not of poor nutrition, then you don't go on to achieve your highest education potential. Then you can't, for example, access the kind of job that you would ideally have accessed. That impacts your income earning potential, your family is impacted, generations from there are impacted. And so the reverse is true. Good nutrition is linked to improved school performance, increased productivity, which leads to long-term economic benefits on individual, and then collectively for a nation leads to better GDP, better development for a country, and therefore also for the globe at large. We are much better off when everybody is of good nutrition. And so investing in nutrition has been shown that it could reach 5.7 trillion US dollars per year in economic gains to society by 2030. Now, improving maternal malnutrition is possible when we invest in women and deliver a package of evidence-based maternal nutrition interventions. And we are doing this, trying to meet some of the goals that have been put out there. We all know of the 2030 United Nations Sustainable Development Goals, where we have made a commitment to tackle undernutrition and hunger by 2030. The World Health Assembly has also given us very ambitious targets that by 2025, most countries have endorsed the World Health Assembly Plan on Maternal, Infant, and Young Child Nutrition, which specified 6 global nutrition targets. First, we are supposed to achieve a 40% reduction in the number of children under 5 who are stunted. Then a 50% reduction of anemia in women of reproductive age. Achieve a 30% reduction in low birth weight. Ensure that there is no increase in childhood obesity, because malnutrition also means obesity is also part of malnutrition. We are supposed to increase the rate of exclusive breastfeeding in the first 6 months up to at least 50% and reduce and maintain childhood wasting to less than 5%. So multiple micronutrient supplements, which, as I said, in some places are referred to as prenatal multivitamins. For this presentation, I'll refer to them as MMS. These are one of the most impactful nutrition interventions that significantly improves maternal health and birth outcomes. And we know this because most diets out there are poor in the sense that they cannot supply all the needed multivitamins or multiple micronutrient supplements. And therefore, this package provides all that a pregnant mother would need in one small intervention. And therefore, it's a unique window to help us stop the intergenerational cycle of malnutrition if we can prevent the mother and the baby from being sick and possibly even dying. So the question is, what is multiple micronutrient supplementation? Now, the WHO or the United Nations calls it UNIMAP. The long name is the United Nations International Multiple Micronutrient Antenatal Preparation of Multiple Micronutrient Supplements. That's what UNIMAP MMS stands for. But we largely normally refer to it as MMS. It has 15 essential vitamins and minerals for pregnant and nursing women and meets micronutrient requirements that poor diets cannot really meet. And so previously, what was recommended was iron and folic acid during pregnancy. Now, WHO has recommended MMS in the context of rigorous research. And what is given is, or rather the recommended dietary allowance for MMS is just one, for example, 1 capsule, 1 tablet per day. And then the woman would get all these 15 essential vitamins and minerals. And these are all the documentations that have been released in support of MMS in various settings. So, and this has come after decades of research. A World Health Organization released a very context-specific recommendations, including in populations affected by an emergency and or experiencing an active tuberculosis outbreak, or in other contexts are supported by rigorous research. And as of last year, MMS is now in the WHO Essential Medicines list, which basically means that now countries can also add MMS into their essential medicines list at country level, and their government and public health stakeholders can go on to recommend MMS to their populations. So in summary, MMS is effective, is safe, is affordable, and is cost effective. And if we adopt MMS, the global impact will be significant. If we transition, if a country, for example, if all countries manage to transition from just iron and folic acid to multiple micronutrient supplements, we will be able to avert between 7 to 28 million additional infant deaths and disabilities across 32 lower and middle income countries. Scaling up multiple micronutrient supplements to 90% coverage is projected to contribute to huge human capital gains for all babies born per year across 132 lower middle income countries. And this will add at least 5 million additional schooling years. And in terms of cumulative lifetime income, we will be able to add 18 billion US dollars. So this is significant, and it's the reason why we decided to organize this session to see whether we can accelerate the uptick of MMS. Now, the WHO calls for rigorous research as you introduce MMS into countries. So the next presenter is going to explain to us what this means. So before Dr. Ashutosh comes on board, kindly allow me to introduce to you Dr. Ashutosh Mishra, who is a medical doctor and a clinical epidemiologist by training. He brings 2 decades of experience working with global public health organizations like RTI International, Clinton Health Access Initiative, and Engender Health, where he was actively involved in designing interventions to reduce morbidity and mortality among mothers and young children. He has significant expertise in implementation research and in developing monitoring and evaluation frameworks for large-scale public health programs. And as a senior regional technical director at Vitamin Angels, Dr. Ashutosh is supporting Vitamin Angel's regional efforts to accelerate the introduction and scale up of MMS for pregnant women in Asia. He's currently based in New Delhi in India. Ladies and gentlemen, I will play now Dr. Ashutosh's recorded presentation, but he's available during the question and answer session in this hour to also answer any questions that you may have. So kindly feel free to type them and post them in the chat. I now play Dr. Ashutosh's presentation.
Thank you so much for that introduction. I've put together a couple of slides to give you an overview of our implementation science framework that can be deployed towards introducing, implementing, and scaling up antenatal MMS. Let me take you through those slides. So what is implementation science? Implementation science is a systematic approach to understanding problems related to program implementation, then identifying and testing possible solutions in an adaptive or iterative process to ensure effective and quality implementation of health interventions, strategies, and policies. Unlike clinical research, which measures health outcomes such as birth weight, implementation research examines implementation outcomes such as feasibility, coverage, cost effectiveness, equity, etc. The key question that gets answered is how much and how well the strategies optimize the intervention to improve MMS uptake and adherence. When looking at implementation science in the context of MMS, the overall objectives are: 1, to inform the implementation and effective scale-up of MMS; 2, to gain operational experience around MMS delivery in the context of ANC services; and 3, to strengthen health systems that support MMS delivery. As you can see from the slide, implementation science approach includes 3 phases, which look linear on the slide, but in fact are often both iterative and fluid, meaning that one often goes back and forth between the phases. Phase 1 includes building an enabling environment for MMS. For example, we often work with local partners to conduct landscape analysis, which are used to better understand the context and stakeholders in which the intervention might be adopted, as well as support awareness raising and consensus building activities that may lead to MMS policy and program recommendations. Next is the designing and testing of an implementation strategy. This often includes formative research to understand barriers and enablers to intervention delivery and uptake. And often it includes an evidence-based process for the co-designing and testing of implementation strategies by local stakeholders. Finally, the third phase is the scaling of the implementation strategy, which is intended to be informed and supported by phases 1 and 2. As you can see, stakeholder engagement cuts across all the 3 phases. It's important again to note that there are many other successful implementation research approaches used by UNICEF and others that follow a similar pathway. And they may look a little different compared to what I'm showing here, but here's what's most important. Successful implementation science depends on local and national leadership and partnership. Now, I will be talking about each of the 3 phases. Phase 1 focuses on fostering an enabling environment, starting with undertaking a landscape analysis. The objective of the landscape analysis is to identify barriers and opportunities for integrating MMS into the antenatal care platform using a participatory approach. Landscape analysis involves review of maternal nutrition situation, antenatal care platform, existing policies and programs, supply readiness assessment, and finally, identification and mapping of key stakeholders. Landscape analysis is followed by awareness raising and consensus building, 2 activities that are critical for informing and planning the next phase of activities. Phase 2 starts with formative research to understand the delivery of prenatal supplements at the national, provincial, district, facility, and community levels, and the barriers and enablers to coverage and adherence. Some of the data collection methods deployed during formative research are comprehensive desk review, quantitative surveys, and qualitative inquiries. Formative research is followed by designing of the implementation strategies. The purpose here is to validate and clarify questions and findings from landscape analysis and formative research and inform implementation strategies that are responsive to program and country needs. Key activities include presenting formative research findings to the broader group of the stakeholders and co-developing and prototyping implementation strategies. Following designing comes the testing of the chosen implementation strategies. The key question to be answered is, how can antenatal MMS be effectively implemented and scaled within the country's national health system context to support improved maternal nutrition? While the study design is governed by the implementation strategies and specific implementation questions coming out of landscape analysis and formative research, outcomes focus on process indicators and contextual influences. Phase 3 focuses on the dissemination of findings along with planning for a national scale-up. The goal here is to develop guidance for large-scale national deployment that supports commitment and action by local decision makers throughout the health system for building capacity of health system personnel, integrating MMS monitoring and evaluation into the health system's existing monitoring activities and national surveillance systems, and financing large-scale sustainable MMS implementation, including demand generation, product procurement, and service delivery needs, such as continuous training and support. This slide gives a quick snapshot of where different countries are in this process that Vitamin Angels is supporting. Let me walk you quickly through a case study on Vietnam. We recently completed a landscape analysis in Vietnam and organized a stakeholder workshop in collaboration with National Institute of Nutrition Vietnam, chaired by the Director of National Institute of Nutrition, with participants from the Ministry of Health, along with international and national nutrition experts. Over 140 participants attended the workshop that identified MMS as a high priority area for Vietnam and recommended setting up an action plan to implement MMS in Vietnam in a systematic way at the national and provincial levels. Some of the specific recommendations that came out from the landscape analysis and the stakeholder consultation workshop held in Vietnam included: 1, expanding the scope of Nutrition Steering Committee to provide political and technical support for MMS implementation. 2nd, to include UNIMAP MMS in the National Essential Medicine List and coverage of all pregnant women through national health insurance. 3rd, to build a committee of experts assigned to support the provinces to create contextually appropriate nutrition action plans, which include MMS. 4th, to conduct a pilot to introduce and scale MMS in selected provinces through the existing antenatal care platform. And finally, to investigate barriers and enablers for UNIMAP MMS production and supply in Vietnam. Thank you so much.
Thank you so much, Dr. Ashutosh, for that really good presentation. I'm going to move straight on to the next presentation, and this is going to be by Hao Kran. Hu Kran is the Deputy Country Director for Programs at Helen Keller International in Cambodia. And from 2015 to 2021, he was a chairman of the SAN Cambodia team. He has a cumulative 27 years of experience in designing and managing nutrition-specific and nutrition-sensitive programs in Cambodia, and has worked with the Royal Government of Cambodia to successfully scale up Cambodia's vitamin A supplementation program, achieving nationwide coverage. He has also overseen the implementation of several trials, including multiple micronutrient powders for children, iron and thiamine supplementation, and the results of which have gone on to inform national policies and guidelines. He played an important role in supporting the development of Cambodia's roadmap for sustainable food systems by 2030. Kran received the Royal Order of Sawatara by the Royal Decree of His Majesty the King of Cambodia for his accomplishments in the fields of food security and nutrition in Cambodia. Ladies and gentlemen, let us listen to the presentation by Hu Kran.
Hello, good evening from Cambodia, everyone. And thank you very much, Dr. Martin, for your kind introductions and for the opportunity to present our experience on what it takes from the landscape analysis to pilot project on multiple micronutrient supplementation for pregnant women in Cambodia. So the overall goal of the landscape analysis was to assess the enabling environment to support a transition from iron folate acid to maternal multiple micronutrient supplementation. And the study has three specific objectives. First, to review the current evidence on nutritional status, national policy and program and monitoring system. Second was to map out the context of readiness for implementing maternal MMS interventions as part of ANC services in the country. And finally, to make recommendations about how to best make investment in order to effectively introduce and scale up maternal MMS in Cambodia. Basically, the exercise consisted of 4 methods, including a depth review of Cambodia's specific scientific and program literature on nutritional status, micronutrient supplementation during pregnancy, the functionality of ANC platform, and the existing national policy and maternal nutrition. Then the semi-structured interview for the stakeholder analysis were conducted to identify perspective on maternal MMS with 4 different group of stakeholders, including the government, donor, UN agency, and civil society organization. The consultative meeting with the government stakeholder and local manufacturer were conducted to gather information related to MMS supply readiness for both immediate and long-term consideration. Finally, the workshop was conducted to build a consensus among the key stakeholders in order to discuss and agree on the next step and way forward. You know, Cambodia is experiencing a shift from high level of undernutrition, especially stunting decreasing from 32% in 2014 to 22% in 2022, toward increasing overweight and obesity. But multiple micronutrient deficiency remain a serious concern in the country. Anemia among women of reproductive age is high at 53%. However, the iron deficiency is low at 3% due to the genetic hemoglobin disorder and thalassemia issue. Multiple micronutrient deficiency are high among women of reproductive age. For instance, zinc deficiency is at 63%, while vitamin D deficiency is at 31%. 38% of the mother with iron deficiency and folate deficiency among women is about 18%. Low birth weight incident based on the maternal recall is ranged from 8 to 12% in Cambodia. So maternal nutrition is supported through IFA supplementation and counseling, which is delivered through ANC service at the health facility. Based on the result from the national survey, attendance at ANC is high, with 95% of the women attending at least one visit. 76% of women attend 4 or more ANC visits in Cambodia, and 94% of women reported that they receive at least 90 days of IFA supplement during the last pregnancy. However, 76% of women reported that they adhere to the 90 recommended dose of IFA supplementation. It is important to know that the rate of ANC attendance vary significantly by the province. with more remote provinces achieving only about 75% coverage for the ANC. So the landscape analysis found that in overall, there is a strong and broad support from the stakeholder to transition from IFA to MMS during pregnancy. And this is really important and helpful for the success of this initiative. During our consensus building workshop, Cambodia stakeholder agreed to shift from IFA to MMS, starting with the pilot project guided by the National Steering Committee, chaired by the Secretary of State for Health, with different stakeholders as a member, including the representative from the government, donor, UN agency, and civil society organization. Based on the plan, we are going to start our pilot project next month for a period of 24 months. Overall objective of this pilot project is to assess the multi-level factor that influence optimal MMS among pregnant women in Cambodia. It is a mixed method study involved with something like pill count, quantitative survey, focus group discussion, community participatory workshop, semi-structured interview, in-depth interview, market observations, and costing analysis. There are 4 aims, as you can see, including the acceptability study for 2 weeks, formative assessment of optimal maternal health facilitator and barrier for 3 months, social marketing assessment for 3 months, IFA versus MMS adherence study for 6 months. So my presentation is ending. I would like to acknowledge Ministry of Health, Vitamin D, Vitamin Angel, and Kurt Humanitarian Foundation for the great support. Thank you very much for your attention.
And thank you too, Hukran, for your presentation, and we look forward to engaging with you during the panel discussion. At this rate, I will stop sharing my screen so that Dr. Mambi, Adama Mambi can share his screen. In the meantime, I'm going to already introduce him. So Mambi, as we call him, is the current head of the epidemiology department at the Center for Vaccine Development in Mali. He joined Center for Vaccine Development Mali in 2005 and has participated in many epidemiological, qualitative, and quantitative surveillance activities, sero surveys, including phase 2 to phase 4 clinical trials performed within the context of the Vaccine and Infectious Diseases Department, and covering various indications such as influenza and meningitis, etc. Dr. Mambi is very experienced in executing and monitoring epidemiological projects and clinical trials. He is also a member of the Ethics Review Committee in Mali, and his work with CVD Mali under the leadership of Professor Samba Sow helps to implement and strengthen disease surveillance at national level and helps to introduce new vaccines and programs into the national immunization program. Mambi, welcome, and please carry on with your presentation.
Thank you so much, Martin, for this introduction. I would like to thank my colleague Aishata for putting this slide together, and all the ANH organization team. So my talk is about implementation research, multiple macronutrient supplementation to ANC in Bamako. So for this implementation research, we use a mixed method, a cluster randomized study designed to with health center as unit of randomization, but we also did some qualitative research. We did that for what? Because we had some research question. One of them is how does the adherence is associated with supplement compared to different study arm, and how the acceptability of MMS is compared. MMS and IFA is comparable among study arms for both ANC client and midwife. And also we wanted to know the level of acceptability of which is associated with our new counseling package, and also to know the cost effectiveness of switching IFA to MMS, considering our Malian context. But finally, we also wanted to know what is the health and the pregnancy outcome associated with MMS and IFA used during the study period. So our objective was to compare adherence among study arm, to compare the acceptability of a supplement across study arm, and also to evaluate the acceptability of the counseling package for MMS. So we had 6 sites, 2 are rural sites, 4 urban sites, for a target sample size of 75 pregnant women. But for the qualitative component, we will do focus group at the end of the follow-up. The enrollment is complete for the moment, but we'll, after the follow-up, we'll do a focus group discussion with midwife, pharmacists, and influential family member, which involved in the ANC management of the pregnant women. So before we launched the study, we did some workshop, preliminary workshop and field testing of our tools. We invite pregnant women and midwife, and also our graphic designer to work together on our materials. So we did a group work on some to draft the counseling tool, to draft the label of the MMS bottle, and so that we can have something that is understandable for the pregnant woman. So we came out with some proposition, sample packaging, but we have to go in the field to test them. So we did those field tests. Also, some idea, what is the ideal counseling session? So we test our counseling package with midwife and pregnant women, and come out with a final product. So this is the field testing here with a midwife, and between a midwife and a pregnant woman. And the pregnant woman give their opinion, what should be changed, what can be adjusted. And out of this, the name of the MMS, we give a new name to our MMS, which is local name. We call it Jigi. Jigi is hope. So this comes from the workshop with the pregnant women, and they propose that they, based on the advantage of what the MMS will provide. So they say that this is really a hope for a pregnant woman in order to reduce this high infant neonatal mortality. And as you know, Mali is one of the countries with the highest in their 5 mortality rates. So we did different approach with the pregnant woman and midwife, and to give their feedback on this labels and uptake tracker. So this is the final logo with a happy mom and a happy woman and baby, and also the local food to show that MMS contain all these elements. You can see sorghum, eggs, meat, fish, corn. So MMS is a product which will help to get all these elements. So this helps a lot to have acceptability, but the study is still ongoing. This is the uptake tracker, and this also comes from the advice from the pregnant women, because they are used to this format of follow-up when they do their routine tontine. We call it tontine. Every woman will contribute for a certain amount of money for each week or each month, and they give that money to one next, and so on. So if you give your money, they will just cross on the day to show that you pay. So we use the same format, and it's easier for the pregnant women to remember the daily uptake of the MMS. So we really learn a lot from this the workshop before we launch. We know that we have to focus on health benefits and clarify negative outcome we are trying to combat, and also to bring the issue closer to home. So we learn that the word choice is very important. If you tell them vitamin or micronutrient, there are some pregnant women, they will not take it because they think that they will be too big. They will gain a lot of weight, and the baby also will be too big, and the delivery will be difficult. So we have to be careful with the word choice. One of learning is that midwives are the most trusted individual in the community, especially with the pregnant women. They perform the counseling, so you need to have them on board, and the counseling will be their job. So the community member, they want the best for themselves, and anywhere, we have different arms, the IFA group and the MMS group. So the MMS group doesn't have a problem, but the IFA, they ask why you just don't start with the MMS with us, considering the benefits. So this is something to consider, but we have to consider also this is an implementation research. It will help to move forward the scaling up. So thank you a lot. This is the end of my presentation. To you, over.
Thank you very much, Dr. Adama, for that wonderful presentation. I think it's very nice to get how you are trying to bring MMS to your country, and I like the new ways being adopted and even being given new tag names and the like. Very, very, very encouraging. So we would like to open the floor to the panel discussion. And so I would ask our presenters to be available for some quick questions. And I will start by Ashutosh. There's a question that was asked by Claudia about if you could comment a bit more on the similarities and differences between the landscape analysis you have done for Vietnam, and try to compare that with what Kran presented about Cambodia. I know you have worked with him closely, and so I'm sure you can be, that's why he also commented in the chat that you can handle this question. So please, over to you.
Yeah, so yeah, thank you for that question. And I just answered that in the chat box. So we did this landscape analysis in Vietnam and Cambodia, and then like as I'm saying, like as we observed, there were many similarities. One, definitely, like both the countries strongly recommended setting up a technical advisory committee to drive the overall MMS efforts. And then the other strong recommendation which was coming out, which was similar in both the countries, was including UNIMAP MMS in the National Essential Medicine list. There was also a very strong call in both the countries to undertake further implementation research to better understand the barriers and enablers around MMS implementation. Coming to scalability, like implementation research will be undertaken in the select geographies in both these countries so that it's well representative of the target population, in this case, pregnant women. So that's how I think so. It's more or less the findings are similar. And I think so, as you described through your presentation, that the problem of undernutrition, maternal malnutrition, it stands more or less the same across all the countries. So the solutions are also more or less similar. They just need to be tweaked and tweaked and aligned to the context of those specific countries. So some cultural adaptation could be required, but then more or less the findings were similar. Thank you.
Thank you very much for that answer. And maybe if I move on to Kran, there's a question for you about your experience in Cambodia. How long would you say does it take from situation analysis, as you explained it, to the MMS pilot project? I think our stakeholders from other countries would want to learn from you. Over to you.
Yes, thank you very much, Dr. Martin. Actually, basically, about a year, I would say, but because the COVID-19, we could not meet face-to-face, so we have a lot of problem with the online interview. And sometimes we can also do face-to-face, but basically it's a year project. Actually, is first, with advocacy with the government officials, and then with different stakeholders, who might be interested in, ANC and things like that. And then we come up with a common idea on how we go about the landscape analysis, including producing the tool and question guide and things like that, and interview, and then consensus building workshop, and then come to the determine the pilot project. So basically it's about 1 year, I would say.
Okay, that's good to hear. I think it's encouraging. A couple of questions are coming in fast on the chat section, and I have also other questions that I had received. So just to mention that we are going to try and answer these questions to you directly. If you send us your email address, we can always send you the responses from the presenters. Maybe very quickly, I would like to maybe pose one question to Dr. Adama, and then give the presenters just the 15 seconds each to give their last words, and then we close, because the ANH would like to keep this to 1 hour. So, so Dr. Adama, the question is here: do you think, and this is coming from Bolanle Popula, I hope I said the name correctly, do you think every woman likes drug? I guess she means MMS, which might hinder the consumption despite availability? I think you are, judging your background as an epidemiologist, you can contextualize a question and possibly provide an answer.
Yeah, absolutely. I think this study is giving us answer to that. With the IFA, women were complaining about the taste, the iron taste. So compared to the MMS, is completely different. So there are some women who are even sharing. We noticed that they want to share their MMS with other pregnant women in the family. So we are really very optimistic that this is going to be accepted by women in our context.
Perfect. That, I think, is a befitting answer to that question. So, ladies and gentlemen, just to mention that the Healthy Mothers, Healthy Babies Consortium has compiled a toolkit for advocacy that you can easily download from the website. And this is especially if you're a national stakeholder, or you're a medical doctor, or a researcher, or it doesn't matter at what level you engage with MMS. If you need to be able to understand it better, to advocate for it, you can just download the PowerPoint slides and then use them for advocacy. And these are found in our website. This recording will be available, as Claudia mentioned. And in case you have any questions, you can also email us directly. So in the next half a minute, I will ask the presenters to just 15 seconds of each say your closing remarks. Maybe we start with Ashutosh.
To me, like MMS, as you just mentioned, like MMS is the most cost-effective, safe, and efficacious intervention. And then now because it has been endorsed by WHO, so I think so we just need to advocate strongly for replacing IFAS with MMS in most of the countries because of the evident like improved pregnancy and birth outcomes it leads to.
Perfect. And thank you, Marty, for posting the link to the HMHP advocacy toolkit on the chat. Ladies and gentlemen, you can just get the copy there. Moving on to Hu Kran, your closing remarks.
Thank you very much, Dr. Martin, for the opportunity to speak today. And I think Cambodia is looking forward to see the result from our pilot, implementation of the MMS in Cambodia. We hope that it will be useful research to share with other countries. But importantly, for Cambodia itself to decide on moving from IFA to MMS. Of course, it depending on costing, in which we will also include in the assessment as part of this research as well, together with vitamin Angel to see, if Cambodia, will be have a sustainable system to replace this. So thank you very much, and we'll look forward to share the finding from the research after 2 years. Thank you.
Thank you very much. Looking forward to those findings. And Dr. Adama, if you can keep it short so that we are not kicked out of the session.
Thank you. So I would like Vitamin Angel to increase the production, and MMS has already fulfilled 3 major parts of the backbone of health intervention to be well updated. The science, the financial, and also the acceptability, as I mentioned. So what we need is the cooperation between all stakeholders to accelerate the scaling up. So for countries who did not do implementation research, use the result of the country who did it and then go ahead.
I think I cannot have put it better than you have. So thank you so much. I shouldn't dilute. And so thank you to our presenters. Thank you to our listeners. And thank you, Claudia.
Yeah, thank you so much, Martin. That was an amazing session. And just a massive thank you to our fantastic speakers and everybody who's been participating in the questions in the chat box.